Okay, what percentage of patients presents with back pain? So low back pain is a predominant presenting diagnosis for about half of the surgeons here. Have you yourself, as a physician, ever had back pain, sciatica longer than 3 days? And that's a very even distribution. That's actually very interesting. A follow-up question on this. Have you yourself ever had surgery on your spine, on your lower back? And
One person.
One person. We're not going to ask for a show of hands. Why did I ask this question? Recently in Europe, and this is very consistent, at a meeting of 220 neurosurgeons and orthopedic surgeons in spine, nobody had had spine surgery themselves. So we are very consistent with our international colleagues. The following speakers will talk about the tremendous cost angle that back pain presents upon the healthcare industry. What we have to be very aware of is that the population, increasingly through the media, perceives our interest as financially motivated. And as I look around this room, I see not a single person for whom I would remotely consider this to be a reasonable assertion. But we have to be mindful of public perception. Low back pain, as I said, is a phenomenally difficult to understand situation with segmental instability and discogenic back pain being two predominant possible causes for back pain. And the disc as a pain source has been identified for a long time by Dr. O'Brien and others and remains somewhat elusive. We've treated cages and we've put patients with pain pumps to try to manage this entity. Recently we've been inundated, and I think the wave was chosen very well, with advertisements about disc replacements. Along those lines, allow me to ask for your public opinion as to the management of this case. A 34-year-old male, he has low back pain with recurrent left lower extremity pain, 50-50 ratio back pain and leg pain. He's had a discectomy at L4-5 3 months ago. If you look very carefully, we can see a fairly sizable left centrolateral recurrent disc herniation. My question to you is, would you have more non-operative care in this situation? Would you advocate a revision discectomy, a fusion of any type, or a disc arthroplasty? So most of you will advocate further non-operative care and a rather conservative approach. I'm very pleased to hear that. In fact, this patient had a disc replacement performed, and his pain is now much worse than before, and he has an incisional hernia, and there's some questions as to how the disc replacement actually is holding up. This is abdominal wall with a previous infection. Now, the final question of this introduction session. Please assume that this is your back. As you'll see, there's a single-level degenerative disc disease present at L2-3 with a mild unilateral collapse on one side and a severe collapse on the contralateral side. This has been going on for 5 years, and you can only pursue your practice in a brace, and you're pretty fed up with it. If you make all these assumptions and you're neurologically intact and are on a regular high dose of anti-inflammatories, how would you want to treat this yourself? Would you live with it? Would you have any form of effusion, or would you have a disc replacement? So a healthy proportion will live with it, and a healthy proportion will have a fusion, and there's one pioneer who will be interested in having a disc replacement. With this, I hope we've set the stage for a further investigation as to the conundrum of disc replacement, and we'll ask Dr. Herring to guide us in the search for solutions.
The next speaker is my associate, Dr. Chris Standaert, who will talk to us about IDET. Chris is a physiatrist, a compassionate doctor with a healthy skepticism, which I think is a perfect combination of traits to really give his patients the best care. Very, very concerned about his patients' welfare and concerned that what he provides them has clinical and scientific basis. Given that platform, he's going to discuss some issues about IDET.
All right, I am talking about intradiscal electrothermal annuloplasty, which is really the formal name of this procedure, commonly called IDET. I will probably use the words interchangeably. Most people do. IDET is actually the trademark name for the procedure and for the device, the equipment. So technically, this is really what we should be calling it. And although we're talking about IDET, I want to think of IDET, the story of IDET, in sort of the greater context of a lot of these devices and other things we're talking about in procedures. IDET, I think that the concept of IDET arose out of this perceived need for something else we have to do for these people who come to us with back pain. And a lot of the other things we're going to be talking about today arise out of that same need. There are a number of other procedures we're not even talking about that are coming down the pike that have the same issue. And I think you just want to keep in mind as we talk about the story of IDET, I think it is sort of an interesting story, what happened with this technology. How does this apply to all the other things we're going to be seeing, we are seeing? So IDET really developed by the Saul brothers. And they came up with this device, this method. They're trying to treat essentially chronic discogenic low back pain. And they were looking at patients initially with sort of more than 6 months of pain not responsive to other conservative treatment. Normal neurologic exam, concordant discography seemed very much like what we would think of as discogenic pain. The idea is you take this catheter, where's my mouse? There it is. You take a catheter, you insert it into the disc, and you wind it around in between the nucleus and the annulus posteriorly. And then you heat the end of that catheter to 90 degrees centigrade over 13 minutes, and you keep it there for about four minutes or so. The idea was therefore you heat the back of the disc. They proposed several mechanisms by which this might actually help or do something for the disc. Perhaps it would shrink collagen fibers and stabilize the disc or seal an annular tear, they thought. Perhaps it would coagulate nerve tissue, so essentially thermal ablation of the nociceptor, so it would fry the nerves so you wouldn't feel the pain anymore. Or perhaps it cauterized granulation tissue. The procedure came out before anybody really had any science about what this actually did. And frankly, since it came out, that really is, the physiological effect is not well proven. It's still very unclear if and what this does. Some of these things it clearly doesn't do. So when it first came out, there were a lot of early non-controlled trials that came out that were fairly optimistic, particularly those by the Saul brothers, which is an odd coincidence. But so in 2002, they published their 2-year follow-up data of their initial treatment group. They had 2-year follow-up. They had 58 patients. The drop on the visual analog scale went from 6.6 to 3.4. It's a pretty decent drop, I think most of us would think. Not perfect, it didn't get better, but they found better SF36 scores. And there are a number of other studies that came out early on, again, non-controlled, small groups, single provider studies, similar findings. I think in the midst of some of the enthusiasm, people missed some of the less promising studies that appeared. This study published by Davis et al. In Spine in 2004 was presented at NASS a couple of years before that. They did a retrospective study on 1-year outcomes from 44 patients who had IDET. Of these patients, 6 had lumbar surgery, 97% still had back pain, 39% had less pain, but 30% still had more pain after the procedure. They found that half the people were dissatisfied with it. It is not a stellar outcome. A study by Friedman et al. From 2003 in the Spine Journal, they looked at 41 active duty soldiers in the military. 6 of these actually had IDET twice. They didn't count those in their final statistics. They were looking for a successful outcome of more than 50% of pain reduction. When they looked at their patients, they found that 65% had a persistent decrease in their pain scores. It's a good thing, maybe. At 6 months, 47% were successful. But in the axiom of nothing lessens enthusiasm like further follow-up, you find that at 2 years, 2 to 4 year follow-up, only 16% were felt to be successful. So time just sort of eroded away what appeared to be a decent success rate. And about a quarter of these people went on to spine surgery. So all these non-randomized studies brought in, obviously, a crying need for a randomized controlled trial. There are a couple of them. There's only been one that's actually been published, and that's the one we're going to talk about, published in full as a full manuscript. This is a study by Pauza et al., published in Spine Journal from 2004. Some of the things what you need to look at in the Pauza study is how they got to the patients they got to. They started with an ad for the study. They had over 4,000 patients respond to their ad. After a telephone interview, they decided they should do a history and physical on 1,300 of them. Of those 1,300, 260 met their criteria and underwent discography. Of those, 64 were eligible for their study. So 64 of over 4,000. They wintered them all out. So they did a 3-to-2 randomization. 37 IDET, 27 sham. The criteria which they found these patients were very, very strict. And I think shows something about how to apply this. They looked for 18 to 65-year-old patients, back pain more than leg pain for greater than 6 months, people who had failed at least 6 weeks of non-operative care, a score of less than 20 on the back depression inventory, so they weren't depressed, and not much disc height loss, and ideally an isolated posterior annular tear when they looked at them on discography. Exclusion criteria. Now think about this in your own practice. How many patients you see who have none of these? I don't see very many myself. previous lumbar surgery, abnormal neuro exam, structural deformity, spondylolisthesis, scoliosis, and a number of other things, disc greater than 4 millimeters, uncontrolled acute or a chronic serious medical condition. So rheumatoid arthritis is the one they used. Spinal stenosis, radicular pain, significant neck or thoracic pain, workman's compensation, injury litigation, or disability payments. So that's a lot of things. I don't see many patients who have none of that. So treatment group, IDET protocol, the thing we just described by the Saul brothers. SAM group is a very well done study. They put the introducer into the aspect of the disc, but they just didn't enter the disc. They put on little sounds and images of IDET. They let the thing run. People really couldn't perceive they weren't getting the procedure done. They sedated them. They did everything they should do. Look at their outcomes. SF36, no real difference. Oswestry statistically favored IDET, not dramatic, but it favored IDET. The visual analog scales, the IDET group is, where's my mouse again? Right here. IDET went from 6.6 to 4.2. SAM went from 6.5 to 5.3. Not terribly overwhelming, I don't think, but better. Pain relief at 6 months after treatment. Greater than 50% pain relief, 38% for IDET, 33% for controls. Greater than 75%, 22% for IDET, 4% for controls. So what they concluded were several things. One, they did not think IDET was a placebo treatment. They thought there was some actual effect here. They said, however, that nonspecific factors are a major determinant for the efficacy of IDET. And the term nonspecific, I can't quite figure out. I think is actually a synonym for placebo, so I find it a little confusing. So after a very rigorous screening process, they found that IDET substantially reduced the pain in only 1 out of 5 patients. And I like this phrase. It came from a recent review of IDET by Chu et al. From 2005. It's unclear how generalizable these meager outcomes are in the low back pain population at large. So it questions the whole study. A couple other studies have been done, and this one was presented by Lau and Bogduk at ISIS in 2004. Hasn't been published that I know of. They looked at, again, a prospective blinded placebo-controlled study, normal disc height, annular tear, positive discography. IDET versus an anesthetic annular injection was their control. And they did a third arm open label IDET group. So there's an active control group and a IDET group. So 10 active patients, 5 sham groups, and 10 open label groups. What they found after those first 25 patients, active blinded group, 20% got 50% pain relief, 10% got complete pain relief. The sham group, they had 1 placebo responder. Pain went away in the sham group, 1 out of 5. In their active open trial, again, 20% complete pain relief. And what they concluded after looking at this, just after 25 patients, they said it would take an additional 40 sham patients, assuming no one obtained complete relief, to dilute this 1 patient to achieve statistical significance. And they terminated the study on ethical grounds. And they concluded that due to the low efficacy of the treatment, the number required to prove it against placebo is exorbitantly high, which is not a very ringing endorsement. So, conclusions about IDET. Again, this is a story, and you have to think about this with everything else that comes out. Very encouraging, early, non-controlled, small trials, very encouraging. There's a lot of enthusiasm about this procedure in the interventional spine world. This would be a great thing. However, it came out without us knowing what it really does and what was going to happen to these people. We didn't know. And when you look at the data we have, we don't have many controlled studies, but even the very best and most rigorous studies, if you even take at face value the statistics, and there are some who question the statistics of the PALSA study, minimally supportive in the most rigorous settings. And I think personally there's no substantial role for this procedure in a standard clinical setting. So it came out, people did a lot of them. I think it's still being done in a lot of places, but I don't know why, personally. I don't think there's any role for it. So we have to be cautious about zealously applying simple solutions to complex problems. These patients are talking about have a disc, but they have 6 months of pain. They failed other things. These people clearly didn't listen to Dr. Fairbank and Dr. Herring before when they started doing this procedure. That's not the issue. So we have to be careful about that. So with that, hope you enjoy the rest of your afternoon. Thank you.
Thanks, Bud. I have the opportunity now to introduce yet another one of my friends, Dr. Ray Baker. Ray is a clinical professor of anesthesia. He is well known for his work in selective spinal injection work, both in his practice as well as publications and lectures. We have taken to referring to Dr. Baker as a conscientious injector, a man who has developed a habit of talking to the patient before he offers him a spinal injection. Ray is going to talk to us about neurotomy and psychopophyseal pain.
Thanks, Dan. You know, I'd like to start out by thanking both Dr. Chapman and Chestnut for the opportunity to talk to you today. I've been asked to talk about the role of medial branch radiofrequency neurotomy for the treatment of low back pain of zygapophyseal joint origin. And really it revolves around two questions. Can we diagnose zygapophyseal joint pain with any accuracy? And is it possible to treat it with a neurotomy procedure or a lesioning of the medial branches? You can see that the medial branches are represented in this cartoon here off of the primary dorsal rami, and send articular branches to the level where they come over the transverse process as well as the level below. So we'll look a little bit closer at our ability to improve this condition now. First of all, how common is the condition? Well, according to Schwarzer in Mangicotti, it ranges anywhere from 15% to 40% of the general population that present with nondescript axial back pain to a primary care physician. However, in a recent email exchange with Nick Bogduk, who's gone over all this data, he says that's probably high, and it's probably more in the range of 10 to 20% if you look at that spectrum, and it does increase with age, as you would expect. So does arthrosis. How do we diagnose it? Can you bend someone, twist someone, extend someone? Can you push on them? Can you do imaging studies to diagnose the pain? Well, the answer, in short, is no. We like to palpate for tenderness. We like to extend and rotate, to do quadrant loading. We like to do bone scans, CT scans, etc. But well-controlled studies have failed to show that any of these are pathognomonic in the diagnosis of zygapophyseal joint pain. So the sad fact is the diagnosis remains one of exclusion, and confirmation of the diagnosis requires analgesic injections of the joint itself or of the medial branches, which, as we'll see in a moment, is also less than perfect. Essentially, if we're looking at a patient for a neurotomy, which patients are we likely to even put in the pool? One is a patient who's had back pain for more than 6 to 12 months, a patient who has failed well-directed non-operative treatment. As Dr. Herring mentioned earlier, it's not the usual care. This is careful non-operative treatment. And a patient who has completed at least 2 sets of medial branch injections, and at times 3 with the placebo-controlled if necessary. Why is it important? Well, we look at the data from Schwarzer and Mangicotti. You go back to the early 1990s, and it was felt that 1 injection was sufficient to make a diagnosis. And if the patient had more than half of their pain relieved, then they had a diagnosis of zygapophyseal joint pain. But what Anthony showed was a full 38% of these patients were false positive, with a dismal 31% positive predictive value. Now, if you raise that to an 80% success in terms of the amount of pain that needs to be relieved in order to have the diagnosis, then you lower the false positive rate some, down to 27%, and you raise the positive predictive value, but it's certainly less than perfect. Well, let's look at some technical factors. We're about to look at the RCTs and the data on the radiofrequency neurotomy procedure. So what are the technical parts of this that might come into play? One is the cannula size. Size really does matter in this instance. The larger the diameter of the electrode, the larger the lesion. And you can see the 16-gauge electrode in green here compared to the 22-gauge electrode here represented in red in the medial branch here as a yellow dot. And you can see that you have to be very close, in fact, 1 millimeter away from the nerve if you're using a smaller cannula, and you have more luxury if you're using a larger cannula to still encompass the nerve within the lesion diameter. These slides are shared from Nick Bogduk and Peter Lau in their work on cadaveric analysis of where the medial branches run and how to best position the cannula. And here you see, let's see if I can get this cursor up again, you see the Z-joint here, the capsule, you see the transverse process coming off here, you see the primary dorsal ramus is underneath this tissue, the medial branch is descending across the transverse process, intermediate and lateral branch. The idea is to place the cannula parallel to the nerve and try to encompass as much of the length of the nerve as you possibly can. And again, you can see that a larger cannula is more likely to do that than a smaller cannula. These are pictures taken, radiographs off of that same cadaver, and showing that under an open dissection, this is the best placement to achieve adequate lesioning of the medial branch. So we want to strive for something that looks like this if we're going to technically succeed. Now let's go and look at the trials as they are. We have 5 moderately well-controlled studies. We have 3 RCTs, 1 double-blind control study, and 1 prospective audit. All of them have problems, as you would expect, and I'll bring these into play. But it does give you a flavor for what we have and the problems that we have. First, we'll look at Wyck Study that was just recently published. It is the largest of the RCTs, involving 80 patients that were randomized. It was not meant to look at the effectiveness of the neurotomy procedure. It was used as a critique on the Dutch guidelines, which, as you'll see, are fairly lax. It's a mixed study population. They had no attempt to exclude other causes of low back pain, i.e. herniated disc, prior laminectomy or laminotomy. Other sources of pain were not looked at. They simply did a single intra-articular injection of local anesthetic, and those patients that were more than 50% improved were included in the study. And as we've already seen, this results in at least a 38% false positive. So right out of the gates, you have a study with a mixed population. They also used a cannula positioning that is perpendicular to the nerve and no one would currently use. You'll see on the right-hand side of the screen the optimal cannula position that lies parallel to the nerve, and you see the Wyck data from their paper, and you can see that these are lying perpendicular to the medial branches, obviously not optimal placement if you want to do a technical lesion of the nerve. And not surprisingly, they showed no statistically significant difference in VAS or the combined outcome measures. Essentially, sham did equally well or even better than did the active group. Van Cleef used almost the same criteria and close to the same methodology, which again is poor, and he had only 31 patients in that group, and unlike the Wyck study, he did show positive outcome, which leads you to question which one is correct. In this case, he showed that 2/3 of the patients were more than 50% relieved of pain, and the VAS drop, you can see, went from 5.2 to 2.8 versus a little more than 1/3 of the sham group. If you remember that number, 1/3, it will come up very frequently in today's presentations because 1/3 is about what you're getting with placebo no matter what you're doing to the spine. And we've looked at this. As far as outcomes, he showed a statistically significant difference in VAS, global perceived effect, oswestry, and analgesic intake. Leclerc published probably the study with the worst methodology. He did a single intra-articular steroid injection. There were 30 different providers, physiatrists, who were doing these injections, all of them according to their own protocol and all of them according to their own intake criteria. Any single day of pain relief in the week following the injection was counted as a positive result. Thus, the nonspecific corticosteroid response that could happen 5 days after the injection, if the patient had a good day, was still considered a positive result, and the patients were included in the study. And not surprisingly, there were no changes in outcome. Now, my partner, Dr. Paul Dreyfus, was part of this study that was published in 2000. It was a prospective study, probably the best study performed in terms of the rigorousness of the protocol and the inclusion criteria. It's important to emphasize here the stringency. He was also part of the RCT of IDET, and he helped to develop those protocols as well. So you can imagine this same amount of care was taken. He screened over 460 patients to get 15 patients that underwent the neurotomy procedure. So if you're doing a lot of neurotomies, or if you're seeing a lot of patients that you diagnose with Z-joint pain, you have to question your methods. He required 80% relief, and he did 2 separate comparative anesthetic blocks in order to decrease the amount of placebo results. With that, he also used a larger 16-gauge cannula, parallel electrode placement, and he did something that no one else has done. He did pre- and post-EMG testing of the multifidus muscle to determine whether he had technically done what he set out to do. He had very positive results. Almost 90% of the patients had more than 60% improvement in pain at 1 year. 60% had more than 90% improvement in 1 year, with a dramatic drop in VAS from 5.1 on mean to 1 post-procedure, with changes in VAS, SF36, McGill, and Roland Morris. Further, he showed that the EMG is a reliable test to discern the technical adequacy of the procedure. One patient did not improve at all, and that patient was shown to have only 1 of 6 nerves adequately lesioned. On average, over 90% were effective in terms of the technical outcome of the procedure. And interestingly, strength improved after the procedure, even though the denervation of the multifidus occurred. This is felt to be most likely because of pain inhibition and disuse atrophy that occurred prior to the procedure, and improvement in strength and function when the pain was reduced. Nerves grow back, and the medial branches are no exception to that. The pain will most times return in somewhere between 10 months and a year. The only study to look at this is that by Schofferman, and he looked at Kine's data over 2 decades of doing the radiofrequency procedure, and he found that on average the relief persisted for 10.5 months, and 85% of the patients who came in for a repeat neurotomy were successful in having their pain reduced again, some up to 6 and 7 times over many years. As far as complications go, Kornick is the only person to look at this, a study that was published last year in Spine, 92 patients, 616 lesions, 1% minor complication rate, such as a neuritis, 0 major complications, no infections, no new sensory motor deficits. In conclusion, I would stress that radiofrequency neurotomy is effective for very well-selected patients. Again, if you're doing a lot of neurotomies or you're sending patients for neurotomy, a lot of them, you probably should question your methods. This is a very select group of patients, garbage in, garbage out. Comparative anesthetic blocks are important. High bars are important to exclude placebo. And we've shown that the radiofrequency procedure is generally safe with few associated complications. Proper electrode size and position are important to optimize success, and you can use an EMG post-procedure to determine if you have a failure of diagnosis or a failure of technique. Thank you.